Okay, Bismillah. My advice before your VIVA, okay, in these few days, whatever your exam tomorrow or in the next few days, you have to revise your notes and the cases you always forget about it, like syndromes, like uh, any systemic disease, like hyperparathyroidism, child physical abuse, tuberous sclerosis, von Hippel-Lindau, like this, neurofibromatosis. All these things you have to revise it before the exam. Sometimes I ask you some questions about this features of this systemic disease and also main types like this. Okay. Next thing you have to be relaxed. Okay. Don't take the virus that is very big issue or something like this. You have to relax. It is just an exam. Take it as a discussion. You are all of you are good radiologists, so you have to go for the exam, not like student. You are a radiologist, so they will show cases like every day daily practice. Okay, so you have to be relaxed. You have to be systematic. You have to be logic in your approach, and don't be panic from any case. Just try to go systematic through the case. Consider the time also while you are doing your viva. If you didn't start well, don't be panic, relax. Maybe you miss one case or two cases is not a big problem. You can compensate it in the next few cases in the exam, but try to be safe. Don't miss safety points in any case. Okay. Be confident. Look at the examiner. Also, before your Viva day, you have to sleep very well. Okay, sleep well, relax, go to the Viva fresh. Okay, don't be stressed. Stress is your enemy in this exam, so try to relax as you can. Okay, uh, let's start our session today. We have six candidates. Every candidate, we will give him three cases. Okay, and he should finish these three cases in 15 minutes. Okay, candidate one, are you ready?
Yes,
How are you?
I'm good, and you? Thank
I'm
you.
fine. How was your short and long exam?
I did, but I don't know. Yeah, it's, timing is a little bit, yeah, with my speeding, typing. Yeah.
Okay, this is normal. You have to write more and more in short and long cases. You will not find the time is too much. Time is very limited, so it is always like this. Okay, so don't worry about that. I hope you did well in the. Okay, consider the time. Okay, you have 15 minutes. I will start my timer. Okay,
Okay.
to finish the three cases. Okay,
Okay. Shall I
I'll give
start?
you the history.
Okay.
Okay, let's start. 14 years old male patient with shortness of breath for 6 months.
Okay. So this is a frontal chest radiograph of a 15-year-old patient who presented
Can
with
you
short.
slightly go back slightly from your mic, please?
Okay. Can you hear me now?
Not so much. You can.
Now?
Yes. Okay. Elevate your voice.
Okay. So this is a
Okay.
frontal radiograph, frontal chest radiograph of a 15-year-old patient who presented with dyspnea. I can see, I will look at the radiograph first. I can see the mediastinal widening in the superior and the lower part of the hemithorax. And the lateral margins are very smooth, and the medial margin merge with the mediastinum. The left cardiac border is obliterated, and also I can see the hilar overlay sign is present, and I can't see the aortic arch very clearly. And it associated with no calcifications or any fat component I can see. There is a pleural effusion in the left hemithorax, and otherwise the lungs looks normal. So this is a mediastinal mass lesions occupying in the anterior and middle mediastinum. So
Which part of the mediastinum?
anterior and the middle, because I
You can
can't see
see.
the aortic arch contour. So it's more likely as I think this is more likely with lymphoma, but I will proceed with the CT chest and abdomen for further evaluation.
Okay, so about the location, you can see bilateral hilum overlay sign, yes?
Yes, I can see, but it is not within the lung. It is mediastinum.
Okay, which part of the mediastinum?
It's anterior because I can't
Oh,
see the left
okay, what's your
cardiac
differential?
border. Lymphoma, as patient is 15 year, and also a germ cell tumor. These are the two differential diagnoses most likely. The other thymoma are very unlikely compared to the. Okay,
Okay,
I will.
can you ask for the remote control?
Okay. I can't see the mouth control. Uh, I can't request my. Uh, give me a second. Yeah,
Okay,
I requested.
okay, approved. Okay.
Okay, I will. I have been provided contrast enhanced axial images of the CT chest. I will go with the images first. Okay. Um, yes, so there is a homogeneous soft tissue mass occupying in the anterior mediastinum, giving mass effect on the heart and also great vessels. And I can see the superior vena cava is compressed, and also the trachea and the great vessels displaced more posteriorly, and trachea and the bifurcation, the carina are narrowed.
What's your final diagnosis?
This is, yeah, and also it has invaded the anterior chest wall. So this homogeneous appearance is more likely with lymphoma. I'll give my findings to the referral clinicians. This patient need to be seen by hematology team. And for tissue diagnosis, we can do ultrasound guided biopsy from this mediastinal mass.
50 years old female patient with acute severe right iliac fossa pain.
Okay, so these are the axial. I think I have to, okay, yeah. Axial images of contrast enhanced images of the CT abdomen and pelvis of a young patient who presented with acute abdomen. I will go through the images first. Okay, I can see in the pelvis there is a cystic lesion. I will go to the pelvis again. Yes, So this is a unilocular cystic lesion in the right adnexia. It's actually located in the pouch of Douglas, and I can see a small thin septation within it. No suspicious solid component within it, and it is more likely arising from the it could be arising from the right ovary, and also I can see there is some thickening around the, I think it's pedicle. And no, I'm looking for any perilesional fat strandings. No
Okay, this patient complaining of acute severe pain.
Yeah, I think there is torsion of the right ovarian cyst. The pedicle is more prominent and looks like a twisting in this CT image, and no associated free fluid. So, and no concerning features of malignancy. And I'm looking, I could see the pancreas also homogeneous. Yeah, I will look at the.
Okay, ignore about the upper abdomen.
Okay.
What will you do next for this patient?
Yes, so this is emergency. This is ovarian cyst torsion. So I'll give my findings. I'll pick up the phone and inform the clinicians, and this patient urgently
Okay,
need
what about the ovary itself?
ovaries. I will look at again. Um, I can't see the ovary separately. I think this prominent area is the pedicle, and I'm looking at the left ovary.
Okay, read the mouse. Look at the coronal. Give me your final diagnosis and the management.
Okay. Uh, yeah, the cyst. Yeah, I think the pedicle is twisted, so it is a ovarian torsion. Ovarian, that is cyst is torsion. And yeah, I'll give my findings to the referral clinicians, and this is a female, and also I don't see any perforation of the cyst, and
Okay, from where this cystic lesion arise?
sorry,
From where this cystic lesion arise? What is the origin of this cystic lesion?
it could be arising from the right ovary.
Okay. This patient, 6 years, female patient, drowsy, okay, uh, complaining of right eye exophthalmos and right lateral rectus pulse.
Rectus pulse. Okay, so these are the okay, I scrolling, yeah.
This is the last cut. Okay.
Oh, last cut, okay. So these are the contrast enhanced axial images of the CT brain of a 6-year-old child who presented with drowsiness. And I will go through the images first. This is the lowest part. So I could see some asymmetry of the cavernous sinus. I'll look at again. Yes, so the right cavernous sinus is enlarged, and that is fill-in defects, and the left cavernous sinus looks normal, And I'm looking at the orbits. The ophthalmic vein is, right ophthalmic vein is enlarged compared to the left side. Optic nerve looks normal. And I don't see a significant inflammatory changes in the tetrabulbar retroorbital region, but I think there is some little bit of inflammatory changes of in the right orbital apex. And I'm looking at the orbit. Globe looks normal and no proptosis. I think extraocular muscles looks normal, but I would like to see the other images, other coronal images. And I will look at in my routine practice, I have to look the brain, and posterior fossa looks normal. And I can see the sinuses, the remaining sinuses I'm checking, and the blood vessels. The gray and my white matter demarcation is maintained, and no hydrocephalus. So in summary, my findings are enlarged right cavernous sinus with enlarged right ophthalmic vein with possible some inflammatory changes in the right orbital apex. So I'll give my findings to the referral clinicians for further assessment. I'll do MI scan brain and the orbits with contrast and inogram. Okay, so these are the axial T2 weighted images of that child. Again, I can see the enlargement of the right cavernous sinus with right carotid artery in cavernous part is narrowed. Yeah, compared to the left side, there are some ill-defined area in the orbital apex, right side. No proptosis and no significant edema in the tetraorbital region.
Okay, what are you suspecting in this case?
I'm suspecting the right cavernous sinus thrombosis.
Okay, what could be the possible cause for this case?
Yes, it could be infection.
Okay.
And it
Any
could be
infection here?
no infection.
Are you sure?
Sorry, I didn't get you. Sorry.
Any infection here in these images?
In these images, yes, I can see the opacification of the mastoid access bilaterally. But I'm not, it is a little bit of far from the cavernous sinus. Yes, it could be infection, it could be inflammation as well. And
Okay.
I don't, yeah.
How will you manage?
Yes, we have to find out the cause for the child. So if it is infections, we have to treat promptly. And I'll give my findings to the referral clinicians. This child need to be seen by pediatric neurologist. And yeah, and we can do cavernous further imaging of the
What will
dural
the neurologist
sinuses.
do for this patient?
Sorry.
What will they do for this patient? Neurologist.
Yeah, so there is a cavernous sinus thrombosis. So child, I think they will treat it with anticoagulant.
Okay, thank you. Well done.
Thank you.
Okay. I'll give you the feedback. All over, you did very well. In this case, there is filling defect in the right cavernous sinus. There is another sign of cavernous sinus thrombosis seen prominent right superior ophthalmic vein. If you concentrate more on the superior ophthalmic vein, you can see there is filling defect through it, so the thrombus extending to it. Here you have to look for the cause, okay? For the cases you detect the pathology, then detect the cause of this pathology, okay? You can look for any associated sinus infection like this. If you look here, you can see there are opacification of both mastoid air cells and the middle air cavities on both sides, okay? And if you go more down, you can see there is collection here in the right parapharyngeal space, okay? MRI confirm the presence of asymmetry and encasement of the right internal carotid and hyperintense signal intensity on the right cavernous sinus and bilateral otomastoiditis, okay, and the right parapharyngeal collection. So it is a case of cavernous sinus thrombosis. Here the infection may spread, hematogenous spread, maybe direct spread, maybe hematogenous spread, okay? Sometimes if you found some frontal sinusitis, sphenoid sinusitis, or mastoiditis, it can cause sinus thrombosis through direct or hematogenous spread. And here the management should be through urgent referral to neurology team for thrombolytic therapy and antibiotic treatment. This case is life-threatening condition. This case, okay, you are safe in this case, you are doing very well. Here, there is a large cyst related to the right adnexia. You can concentrate in this. Maybe this is the right ovary, okay. And on this image, I'm not convinced about the twisted pedicle, but it's suspicious. So I have to correlate with the other orthogonal planes. Don't forget, every one of you, don't forget to look at the other orthogonal view, okay, or other sequences in the MRI. Don't try to finish the case while you have the chance to see more obvious sequence or more obvious other multiplanar plane. Here, if you look at the coronal, you can see swelling of the right adnexia. So it is ovarian torsion. The leading point of right ovarian torsion here is this large cystic lesion. Okay, so the emergent case, you have to urgently refer the patient to OB/GYN team. This case is anterior mediastinum, okay, but you can see here it is extending above the clavicle on the right side, okay, and continuous with the right heart border, so it is likely to extend to the posterior mediastinum also on the right side. So it is multi-compartmental lesion. No differential density here. Here, the possibility of middle mediastinum not present because there are bilateral hilar overlay sign. Okay, so it is anterior and posterior. On the CT scan, with contrast, you can see floating vessel signs through the lesion. There is a massive effect also on the trachea, so it is very important to maintain the airway of this patient. And also you can significant narrowing of the superior vena cava. However, no significant collaterals and invasion of the chest wall. So this patient need urgent referral to oncology anesthetist first to maintain the airway, and then oncology MDT for biopsy and further staging, and may need PET CT scan for lymphoma and further management. Okay, thank you, candidate 1. Well done.
Thank you very much.
Candidate 2.
Hello.
How are you?
Hi, thank you very much. So actually, I'm not on a workstation. So if you can just scroll for me, that will be a bit easy for me.
Okay. This patient is 50 years old. I'll make the timer. This patient is 50 years old, female patient with right eye symptoms and headache. Okay?
Okay, so 50-year-old female with right eye symptoms.
Yes.
Okay. Yeah, so this is unenhanced CT. I see the gray-white differentiation is intact. I see there is essentially a dense mass involving, a little r. So at the level of right cavernous sinus and suprasellar area. If you just kindly, yeah. So here. So yes, I can see there is yes. Well, here, if we can just stop a little bit, I can see there is a dense mass involving the sella and also involving the right cavernous sinus. This has seems to be occupying most of intracavernous area or maybe suprasellar area. This appears to be dense. There is. I just want to see if there is any calcification within it, and just will normally want to see the extent and involvement. If I can just slightly scroll up and down. Okay, so yes, so I can see this. There is some extension with within this sphenoid sinuses as well. Okay.
So what are you suspecting?
So here, because of this dense mass, this is involving, first of all, this appears to be extraaxial within the, either it is cavernous sinus mass, and it can be meningioma, or it can be, because it is obstructing, or it can be some hypothalamic lesion from the pituitary.
Where is the epicenter of this lesion?
The epicenter appears to be on the suprasellar area. In this cellar area, yeah. So
what's your differential?
So in these settings, as I mentioned, I would think of the stalk lesions, for example, that can be hypophyseal lesion or it can be meningioma. But since it is occupying the majority of the right sinus, and so
what will you do next?
I'm just thinking of lymphoma as well. Yeah. So here I just want to give my impression to the clinical team, and I would suggest MRI with contrast. Okay. Yeah, this is contrast enhanced image. I can see there is homogeneous. There is enhancing mass occupying right half of cavernous sinus, and if you can just stop at the level of at the level where this the sinus is, just want to see how the cavernous the arteries are. So they does not seem to be damaged by the mass, so they are not compressed, and as I mentioned, this appears to be occupying the whole compartment. So I'm considering this could be lymphoma or hypophysitis lymphangitis. So
any other possibility?
So as I mentioned, the other possibility, meningioma can be the cause, but that will enhance more rapidly and will have more just only yes. So here I see that this can be meningioma, which is causing some obstructive mucocele probably in the sphenoid sinus, but either it is invading. The other possibility, it can be
What are the commonest lesion, common cellular and supracellular lesion?
Yes, so this can be macroadenoma, but this appears to be very enlarged and occupying a lot. So macroadenoma can be a possibility with this lesion.
How will you manage this case?
Sorry?
How will you manage this case?
So this case, I think this I will actually see the other T2 as well to see actually this mass.
Your
more
time
in
is
detail.
finished. How will you manage?
So the this need to be referred to the neurosurgeons because they this mass need to be removed. This occupy a very important area, and it is actually incorporating the visual apparatus, so that need to be removed by transperineural surgery.
Okay, this patient, 30 years old, female patient, 10 days post-operative, presented with vomiting.
Okay, so post-op patient presented with vomiting. Okay, I can see this is unenhanced CT through abdomen and pelvis, and which has dilated bowels, free fluid, and some density within the middle abdomen. So if that post-operative, is this the given that which surgery was done, or it's just post-operative?
Post-operative.
Okay, so in the post-operative settings, first of all, that will be important that it is immediate or delayed. However, this seems to be has some intra-abdominal
10 days
gas.
ago. 10 days
Sorry?
ago. 10 days.
10 days ago. So in that settings, the free gas is out of proportion, and also I can see the bowel which is like dilated does not should not be after 10 days appearing like an IES post-op. It is out of proportionate to the timeline of surgery. So I would definitely will be concerned of yes. So the contrast enhanced images will be helpful to understand the vascular anatomy and okay, here I can see small amount of pneumobilia, and also the large amount of gas. So there is some anterior defect.
Did you detect what is the type of operation or not?
So, well, no, I have not been able to detect that. There is some anterior so, well, I just detected there is some perforation within the gastric or duodenum. If I would just go in that area, I think there might be some area where it is perforated and there is actually a large amount of gas. I just want to.
What is this?
Oh, so that can be just if because
Okay, this patient underwent right hemicolectomy.
Okay, right hemicolectomy. That means yeah. So if the right hemicolectomy was performed, so I was expecting a bit sutures on the other side. Here there can be some retained products, or it can be.
These are the surgical clips.
Okay, all surgical. So in the right hemicolectomy, normally we would expect on the left side, but if they are surgical clips, so there could be an anastomotic leak or any.
Okay, what is the main abnormality here? Look at
the main abnormality is actually, as I mentioned, there is a large dense fluid and also large amount of air fluid. So normally I would want to see the area of.
What's your opinion about the bowel loops?
So bowel loops are dilated. So as I mentioned, this post-op can be, but they are not out of the proportion for the IES because they are quietly
okay, if you detect dilated small bowel loops, what you will search for?
So want to search for like if there is any sort of transition point, which I have not been able to see at this point of time with these images. So in that area,
Okay,
which
can you please look at the region surrounding the
yeah.
surgical sutures?
Okay, yeah. So that if I would just study more in detail, that spot, yeah, I see there is exactly there are fat standing, and yes, so here I can see there is um, uh, notch which is likely to be at the point of anastomosis. So that can be the anastomotic stricture, but that is a very less time to develop. I think there could be some descents at the point of surgery. So the post descents which has caused pneumoperitoneum as well as inflammation throughout the bowel, some obstruction. So this is quite an emergency that need to be again referred to the surgeons to probably that would require another laparotomy to actually fix the area of the point of obstruction.
Okay, 30 years old male patient with trauma.
30-year-old male patient with trauma. Yeah, I can see this bone window in the axial format. So here I just want to, yes, so I just want to see all of the cervical spine, especially starting from the top bit. And okay, yeah, so so here I have this suspicion on the upper cervical vertebrae. So normally I just want to go more, like for example, if that is any sagittal available. So here, yes. So there is some. So the occipital. So the yeah. So I think there is some subluxation at the level of occipital cervical junction. Just want to study that area again. If there is any subluxation at the area of so here yes. So yes, here I think there is some yes subluxation, and then just want to see the atlas if there is any fracture involving. So, yeah, so this area I think there is quite subluxed, and just want to inquire the arc of C1 if there is any injury involving the arc of C1. However,
Anything else?
So I think this vertebral foramen on the left side also not thoroughly. I can see it well. So this needs to be quite. I mean, to be seen properly in the lateral format and in the other formats as well. And then if that is a positive, yeah, okay, here, yes, yeah, here I can see there is a quite extensive injury involving the so first of all, there is a retropulsion of the 2, 3, 4, 5, 6 vertebral body which has been retropulsed. That would actually again an emergency that need to
What
compression need to be
as
ruled out.
regarding the relation, which vertebra is abnormal?
So the fifth vertebra, which is actually there is enterolithiasis of fourth and fifth, but the fifth has actually retropulsed back. So that is likely to cause, because that is causing the canal narrowing. So most probably that would have caused any myelopathy. So I would actually raise it as urgent to look to see the spinal cord as well. And here I just want to again study the whole the cervical. So yeah, so as I mentioned, this is appears to be unstable. Unstable. Yeah, there are the locked facets as well at the same point. So fourth and fifth. So the that appears to be a quite unstable injury that would require an urgent.
Okay.
Yeah.
Give me your final diagnosis, please.
So this is unstable fracture at the level of 2, 3, 4, 5, like 6, and then there is anterior hematoma as well, and this likely to have caused myelopathy secondary to trauma. So the
Is it stable fracture or not?
No, it appears to be. No, it is. There is a lot. I think this is unstable fracture, and because the posterior elements that were also. Can I just quickly see the posterior elements if they have any fractured line going through? I think this is I would categorize it as unstable.
Okay, how will you manage?
So this need to be referred to the urgent to the spinal surgery post the post MRI scan. So that need to be fixed. That need this spine.
What other unstable cervical fracture do you know?
So unstable cervical fractures, for example, if there is any flexion or any extension injuries with more than two or more than two column injury, that can present in any teardrop or the log is also because whichever the injuries which can actually cause damage to the critical structures, that should be categorized as unstable and abnormal.
Okay,
because they are unstable.
Thank you. Okay, the importance of axial, okay, that you can detect the facet, okay, and also detect any Jefferson fracture or hangman fractures like this, okay, because this patient of cervical trauma. We will go through the axial. Okay, you can see this is a normal facet. Okay, you can see my mouse like
yes.
hamburger sign. Okay, so you have to trace like this. Okay, here this is normal, and the vertebral body and foramina, all this normal, pedicles, lamina, spinous process. Okay, and this is also the normal. What's your opinion about this?
Yeah, so this facet I've seen that is a reverse Hamburg sign. So that I mentioned that in the sagittal. So I saw that was perked facet, which was on the axial. It looked like a reverse Hamburg sign.
Okay, so if the examiner give you the axial, okay, you should do your best to detect the abnormality. Okay.
Yeah.
Because when he give you the axial, he needs from you to detect the abnormality from the axial. Okay, he knows that in the sagittal you will pick it. Okay, but you have to do your best to find any abnormality in the axial views. Okay, and then if you detect the abnormality in my routine practice, I will go for sagittal view. Okay, to confirm my diagnosis and search for any other associated fractures and complications. Okay.
Yep.
So here we can go to the sagittal. We have first facet bilateral, okay, reversed hamburger sign. So you can detect the level in the axial, but it will be difficult. But on the sagittal, this is 2, C3, C4, C5, C6. So it is C5. If you go lateral, you can see this is a normal facet. This is a abnormal locked facet. Okay. You can go to the other side also. Okay. And there is also locked facet on the other side. And there is about 50% anterior lysis of C5 over C6. So we are suspecting spinal cord injury. So this patient need urgent both the patient in collar and urgent referral to a neurosurgical team. And this patient may need MRI for assessment of the cord. Okay?
Yep.
So you have to revise all the cervical fractures. Unstable cervical fractures include Jefferson fracture, burst fracture of C1, hangman fractures, bilateral pars fracture of C2, and flexion teardrop fracture, bilateral facet dislocation. Sometimes the extension teardrop may be stable, may be unstable fracture. Okay, all of them urgent referral to neurosurgical, urgent MRI if the patient has neurological deficit to assist the cord, and urgent putting the patient in collar. Chance fracture is seat belt fracture, come in the lower dorsal and upper lumbar spine candidate 6. Okay. This patient, case of small intestinal obstruction. If you detect intestinal obstruction, you have to search for transitional point and search for the cause. What are the common causes for small bowel obstruction?
So the mechanical causes, post-op, you mean?
Okay, common causes like adhesions, okay, but this patient 10 days ago, so not yet adhesion formed. External hernias like femoral, umbilical, spigelian, any type of external hernia. Internal hernia, okay, like paraduodenal hernia or any site of previous operation. And the last one, if you couldn't detect any cause, will be ileus, okay? So here you have to detect, is there any cause or not? Okay, if there is no cause, okay, so you can give ileus, but it is not possible in the exam. Possible in the our routine daily practice, but in the exam it is not possible. Okay, so what's your opinion about this region? There is swirling here. Okay, can you see this swirling?
Yeah.
So swirling means what?
So swelling means there is some internal rotation.
Yes, there is some internal rotation, internal hernia. Okay, related to the site of operation. Okay, you know the mechanism of internal hernia, some defect in the mesentery, and one of the bowel lobes enter through it and causes closing of the bowel lobe and obstruction. Okay, okay, this air may be post-operative air, but it is extended more than the expected time, or maybe suggesting any perforation, but we couldn't detect any abnormal area of loss of enhancement of the wall of the bowel. Okay, so it is a case of internal hernia. As you told, urgent referral to surgical team for reduction and surgical management. Okay, invasive microadenoma. Put it in your mind. Okay, macro, invasive macroadenoma, not macroadenoma. Okay, so hyperdense lesion, okay, extending from cellular and supracellular and the paracellular and sphenoid sinus and petrous apex. Okay, so you should ask here in for the bone window also. Okay, there is bone destruction seen. Okay, and the extension to the sphenoid sinus. Okay, so possibilities like maybe meningioma, invasive macroadenoma. Okay, as you told, maybe lymphoma. So we have to go for the MRI. Okay, MRI, it is homogeneously enhanced lesion. Okay, compressing the or elevating the, if you look at the coronal, the chiasm here, okay, and causing massive effect and extended to the paracellular region and encasing the internal carotid artery and go to the cavernous sinus on the right side like this. Okay, so but also invasive macroadenoma in your first differential in this case. Okay, lymphoma could be a possibility, but common is common. Okay, macroadenoma is craniopharyngioma, no calcification. Okay, it is not supracellular, it is cellular and supracellular mass. So it can be invasive fungal, no such more density inside it. Okay, but it can be a possibility also. But craniopharyngioma not a possibility because the epicenter of the mass is cellular and supracellular. But craniopharyngioma will be mostly supracellular. Okay.
Doctor, this is invasive macroadenoma.
Yes, invasive macroadenoma. Okay, and urgent referral to ANT and neurosurgical MDT for surgical management. Okay.
Okay. Thank you.
Thank you. All the best. Candidate 3.
Yes, sir. Assalamu alaikum.
Alaikum assalam wa rahmatullahi wa barakatuh. How are you, Candidate 3?
Yes, sir. I'm good. Alhamdulillah.
Just I will mute. Okay. Please everyone mute yourself. Okay, thank you. Okay, Candidate 3, I'll give you the history for your patient.
Okay.
Just start the timer for you. 15 minutes. Finish the
Okay.
3 cases. 20 years old male patient with chest pain.
Okay. This is a frontal chest radiograph of a of a 20-year-old male patient who presented with chest pain. I'm looking at the radiograph, and I can appreciate that there is a hyper density or opacity noted in the retrocardiac region on the left side, and there is also some lucency projected over it, and okay, the CP angles are sharp, and the uh, medial half of the hemidiaphragm is not clearly visualized. There is also some volume loss on the left side, and the right lung relatively appears unremarkable, and there is also slight um, okay, and there is some tracheal shift towards the right side. And okay, apart from this, no other significant abnormality is noted. If the patient has presented with acute symptoms, I would be concerned that this patient has some retrocardiac pneumonic patch and or consolidation, and I would refer the patient back to the GP for initiation of the therapy, antibiotic therapy, and repeat the radiograph.
Any other any other finding here?
Yes, I could appreciate that there is some lucency projected over the left hilar, and this is a rounded lucency.
Where is the left
And
hilar? Can you ask for the
part-
remote control, please?
yes, sure. Yeah, here I could this one.
Approved. Click once and show me the left hilar. Okay, is this the
Yes,
left
this
hilar?
yeah, this is the left hilum, this one, and
Okay.
it is projected over it. It is
The
projected
region.
over
Okay,
it.
maybe the region of left hilum. Okay, what is this?
Yeah. It is very well-defined lucency, oval in shape, and it has some internal hyper internal hyperdense component, and the margins are very well-defined and lucent. I would be concerned that it could be any lucent foreign body also, but as the patient is adult, so I'm not thinking on that lines. And apart from this, it could be any maybe uh, any foreign body device, or maybe I'm not sure about this one.
Okay.
And if the
What
yeah
what about the retrocardiac opacity? What are the differential for this one?
yeah for this retrocardiac opacity, I'm thinking that it can represent, if this is non-resolving, then it could represent any sequestration in this patient, or it can be yeah, it can be any atypical infection, and other differential, if it has been a child, it could be any but it is not rounded. Otherwise, I would have thought of any round pneumonia also. So most likely it is,
Any other
if
possibility?
it is not, yeah, sorry.
Any other possibility?
Yes, it can be. Now I'm thinking that maybe this lucent area and this opacity, maybe it is representing any hybrid lesion with multiloculated lucences over it. So maybe it is a complex lesion with sequestration and CPAM. And this is also one of the possibility, or it may be sequestration with superimposed infection also.
Okay,
And
what will do next for this patient?
next, I would proceed with the CT chest with IV contrast to further characterize the nature of the lesion. Okay, I'm presented with the coronal images of the CT chest with IV contrast. And here I could appreciate that, okay, this mass lesion, it is, okay, the lesion is enhancing avidly. And
Please
okay,
go
I
back.
would like to look at the,
Please,
yeah,
please go back from the screen. Relax.
okay. I would like to
Okay.
look at the axial images as well, to look for
Unfortunately,
any
no available
evidence.
axial. No available
Okay,
axial
okay.
section.
Here I could appreciate that there is an opacity noted within the left bronchus, and it can be any carcinoid that is likely causing this collapse. And so I would be concerned about it, and I would convey the findings to the respiratory team.
Where is the
And
left main bronchus? Where is the left main bronchus?
okay, okay, I'm gonna show you this one here,
No, no.
in which there is a rounded opacity. That
Can you
is
scroll?
also,
Okay. What is
yes,
this?
yes, this one.
Wait. Leave the mouse.
Okay.
If you want to know the main bronchus, go to
Yeah.
trachea first. Then what
Okay,
is
okay.
this?
Yeah.
Okay.
Yes, this is the main bronchus. This is maybe the upper lobe bronchus. Yeah,
This is the upper lobe bronchus. What is this?
yeah. This is the. Mentioned that this is a rounded mass lesion. It can, but it is
Wait.
continuous with the vessel. Yeah, it is
Okay.
continuous with the vessel. Yeah,
Okay.
and
What's happening here? What is this?
okay, this aberrant vessel maybe, or is causing compression on the upper lobe bronchus, and it is causing the collapse.
What is this density, please? This one.
This is air. This is the,
Okay. Is it normal to see air
yeah,
around the vessel?
no, it is not normal. Yeah,
Okay. So what is this?
it is likely representing some focus of infection maybe around the vessel.
Okay. What is this?
Yeah.
Triangular opacity.
I said that it is likely a left lower lobe collapse.
Okay. Thank you.
Yeah.
Okay. This patient, not this one. It's no available history for this patient.
Okay. Okay. These are the axial images of the MRI. Sorry, I'm unable to scroll it.
This is the last cut. Go in the reverse direction.
Okay. 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 I'm scrolling through the images. These are the MRI abdomen images, T2 weighted. And first, I will scroll through the whole stack of the images, and then I will start speaking about my findings. Okay, this is the last cut. Is it the last cut? Because I'm
Yes.
unable to scroll further than it. Okay. Okay. I will scroll back. Okay, here I could appreciate that bilateral kidneys are normal. I can appreciate that within the, I'm trying to look for the pancreas. And okay, I could appreciate that the pancreatic duct is dilated and tortuous.
Okay.
And yes, the side branches are also dilated and tortuous.
Okay. What
Okay.
else?
There is no evidence of, yeah, I'm looking at it. Okay, I'm trying to look for any evidence of any calculi within it. However, okay, yes, I could appreciate few calculi. that are giving the filling defects.
In the pancreatic duct?
In the yes, at this point, few, yeah, like this one in the tail region. Not in the duct, but in the pancreatic parenchyma, I guess.
The patient is complaining of
Maybe.
jaundice.
Okay. Yeah, I'm trying to look for the cause. Okay, the gallbladder is also distended, and I'm actually these are not scrolling so well on my side.
Scroll slowly.
I'm coming to the liver. Yeah. Okay. I can appreciate that there is dilatation of the intrahepatic biliary channels, and I would like to look at the point of transition. CBD is also dilated. And as I mentioned earlier, that the pancreatic duct is also dilated. So
Okay.
these
Did
are
you
in keeping
saw?
with giving a double duct sign. And here I
Okay.
could appreciate that there is a mass lesion noted in the uncinate process of the pancreas. Yes, which is acting as the point of transition for both of these ducts. And I would be concerned about pancreatic malignancy. I'm concerned about pancreatic malignancy, and I would convey the findings to the hepatobiliary team. And I would also like to look at the post-contrast images for further confirmation. And yeah, okay, now I'm provided with the post-contrast images. Okay, again, these are not scrolling on my side,
Click,
maybe in the
click, click,
reverse.
click once and scroll.
Okay, okay, okay. Okay, I'm able to scroll it now, and yes, I can appreciate that the same findings are redemonstrated, and there is, uh, uh, okay, yes, mm,
What is the expected pattern of enhancement of this lesion?
it should be enhancing less than the normal pancreas.
Okay. Give me a final diagnosis and mental.
Okay, uh, okay, next, I'm looking at the vessels as well, and the CBD is dilated till the last and till the ampulla, while the pancreatic duct is dilated till this mass lesion. And uh, apart from this, it is not encasing the main vessels. So next, I would convey the findings to the hepatobiliary team, and also I would first look at the MRCP images also for further
What
evaluation. And
what will be the value of MRCP?
for further confirmation, I would have just a look at that, and I would
Okay, no
also
need
like
for
to look at the.
MRCP. Okay.
Okay, okay. Next, I would convey the findings to the hepatobiliary team, and I would advise for ERCP and biliary brushings, and also discuss at the MDT for further surgical planning.
Okay, 80 years old male patient with acute vertigo and unsteadiness.
Okay, acute vertigo and
Unsteadiness. Unsteady
okay,
patient.
okay, okay. These are the axial images of the CT brain, and
Go in the reverse direction. Yes. Okay.
okay. Okay. Okay, I'm scrolling from the caudal to cranial, and I could not appreciate any crowding at the level of the foramen of magnum. Now I'm scrolling upwards, and okay, I'm trying to look for any obvious abnormality, and okay, I could appreciate few areas of hypodensities noted within the uh, centrum semiovale and also in the bilateral frontal regions and bifrontal regions. And okay, apart from this, now I'm looking at the sinuses, venous sinuses
Patient is
also,
presented with
and
acute vertigo and unsteady
vertigo.
gaze.
Okay, okay. Yes. Yeah, okay, now I'm looking at the cerebellum and because of the complaints of the patient. And okay, in the first scroll, the cerebellum appears unremarkable. And okay, here I could appreciate that there is some hypodensity noted in the region of the left cerebellar hemisphere near the sigmoid sinus. I would like to look at this on further MRI imaging for further evaluation.
Where is this hypodensity?
In the region of the left cerebellar hemisphere, here, in this region.
Okay, what are you
Yes, in the
suspecting?
whole of the. I'm suspecting any infarct, and it can be due to pica infarct or due to any uh, vertebral artery dissection, and in this region.
Okay, leave the
And
mouse.
yeah,
Scroll. Click once and scroll.
okay. Okay, here I could appreciate that there is diffusion restriction in the set area, and this is again in keeping with the infarct. And I would like to look at the status of the vertebral artery and also correlate with the history. If the patient has any history of trauma, if the patient is young, then I would be thinking on the lines of any traumatic injury leading to the vertebral artery dissection and causing this infarct. And
No history of trauma.
okay,
Okay.
and otherwise it can be yeah, it can be
What will be the management?
even with the management of this would
Can
be
be what?
yeah, it can be even with the blunt trauma or even with the neck movement, excessive neck movement can even sometimes lead to vertebral artery dissection. And Mm, okay, and the management in this case would be that I would immediately convey the findings to the stroke team and for the patient as this is involving the posterior fossa and it is causing infarction. Um, in this, if it is the involvement of the vertebral artery, then uh, we will. Um, in the case of this, I would refer the
Okay.
patient for anticoagulation and yeah.
Okay. Thank you. Thank you.
Mhm.
Consider the
Mhm.
time. Okay. Well
Okay.
done in this case because it's very subtle finding. Okay. So here the history is very important. Okay. So acute vertigo, unsteady gait, you should concentrate on the brainstem and cerebellum.
Cerebellum.
Okay.
Yeah.
All these are in
Yes.
just white matter evolutionary changes. Okay. No any
Yeah.
territorial infarction. But if you go
Mm.
down, compare both sides of the cerebellum. Okay. If you compared here, you can see there is hypodensity here. Okay, on the left side and the right side appears
Yeah.
here also. Okay, here you compare both
Yes.
sides. Okay, sometimes it come like this.
Yes.
If you are stuck in the exam, you can ask the examiner, please, in my routine practice, I will change the window, darken the window to see any subtle hypodensity. Okay.
Okay.
So
Okay.
as regarding patient 80 years old with vertigo and unsteadiness, so I'm suspecting acute infarction along the left cerebellar hemisphere, along the territory of left posterior pericerebellar artery. Okay, so if the patient on the table, I will advise urgent CT angiography. If not, I will do MRI and MRA. Okay, here is a diffusion confirms the presence of infarction. Okay, so this patient need urgent referral to neurology team if the patient in the window for thrombolytic therapy. Okay, and also consultation of neurointervention for possibility of any thrombectomy or something like this. Okay, this okay, this case you did also very well. Okay, you detect first of all, look at the liver. You can see there is dilated bile ducts intrahepatic, and if you follow them,
Yeah, I saw that, but my images were not scrolling then, so I
no,
couldn't go there.
no,
Yeah.
no problem. If you faced any technical problem in the exam, inform the examiner to stop your
Yeah.
time. Okay.
Okay.
So you can
Yeah.
see dilated CBD. Okay, you can see there is some air here, air fluid level seen within the bile duct. Okay, and you can see
Yeah.
dilated, irregular shaped uh, pancreatic duct. All these are side branches of the pancreatic duct. So we
Okay.
have double
Yes.
duct sign. Okay, simply
Yeah.
should be in, and this patient appears to be old age. So you
Yeah.
can see the muscles with fatty infiltration like this. Okay, so you are
Yes.
have to suspect any pancreatic head mass. Okay. Actually, this
Okay.
patient
Yes.
underwent stenting. This you can see inside this. This is a stent inside the CBD. Okay.
Okay. Yeah, now I
Okay.
can, yeah. Yeah, I can see the
Okay.
lumen. Yes.
Okay.
Yeah.
And then
Yeah.
there is some air post stenting. So next, no value of MRCP. What is the value? What it will add for you? MRCP is
Okay.
heavily
Yeah.
T2 weighted sequence for just to see the bile ducts. And already we
Yes.
saw them, so no need.
Mass.
Next,
Yeah. Okay.
next post,
Okay.
post contrast is the
Yes.
of the highest value. So
Yes.
post contrast we have to see the hypo-enhancing pancreatic head mass.
Yes.
Okay,
Okay. Yeah.
okay. So it is
Yes.
pancreatic. Here, if we don't know there is no stenting, so urgent referral to gastroenterology for insertion of stent to drain the uh,
The biliary system.
biliary
Yeah.
system. If not, we can do interventional radiology through BTC drainage. This case, I don't know why. It's simple case. Okay. Uh, this left lower loop collapse, retrocardiac triangular opacity.
Yeah.
We couldn't. We can see here the right lower loop pulmonary artery. Here we couldn't. It is within the lesion. It is within the
Yeah.
collapsed segment. What is this? Just simply pneumomediastinum.
Okay.
Air
Okay.
within the mediastinum. Okay.
Okay. It was very loculated. Yeah. I haven't seen it like
Is
this before.
encircling the left pulmonary artery, main pulmonary artery. Okay,
Artery. Okay.
okay,
Okay.
go
Yeah.
around
Yeah.
it. So simply
Yeah.
it is an asthmatic patient with left lower loop collapse and pneumomediastinum.
Okay.
Uh,
Okay.
so here this is not a mass, not anything else, just lobar collapse with vessels through it. Okay, your
Yeah.
value, your rule here to exclude any endobronchial lesion, maybe this one, maybe mucus plugging, maybe carcinoid. Okay,
Mm-hmm.
you have to give the
Yes.
and this air around. If the structure rounded like this, follow the structure. If you follow it, join
Yeah.
the pulmonary. This is the
Yeah,
pulmonary.
yeah, but it was very loculated, yes.
Okay, okay,
So,
but
yeah, pneumomodiastinum didn't come to my mind. I
yes.
have
So
never
you have
seen
to
such loculated.
yes,
Yeah.
no problem. Simple thinking will reach the. And here you
Yeah.
can see there is some hyper density here, maybe carcinoid, maybe
Okay.
mucus plugging. So you can recommend
Okay.
gallium dotatate scan like this. Okay.
Okay. Okay.
Thank you
Thank
so
you.
much.
Thank you.
All the best.
Thank you so. Thank.
Candid, welcome. Candid 4,
Yes.
how are you?
Yeah, I'm fine. Alhamdulillah.
Okay. Start your time.
Okay. Should I start?
I'll give you the history. 2 years female
Okay.
patient with shortness of breath for 6 days.
All right. This is chest X-ray frontal projection of a skeletally immature patient of a 6-year-old child who presented with shortness of breath for 6 days. I can see that there is complete opacification of the right hemithorax and there is ipsilateral mediastinal shift noted. In this age group with total lung collapse and acute history, I will be thinking on the lines of foreign body with a complete collapse of the lung. In my routine practice, I will like to compare with any previous radiographs if available. Otherwise, I will urgently convey the findings to referring physician. And after discussion, I can arrange for low dose CT scan for further confirmation of the foreign body, and then patient can proceed with bronchoscopy and retrieval of the foreign body.
Okay. Other than this possibility, what are the other possibilities for this appearance?
If the patient do not has any acute symptoms or acute history, then other possibilities can be of a right lung hypoplasia or agenesis. Another possibility can be due to hypoplasia of the right pulmonary artery. Um, because there is ipsilateral mediastinal shift. So yeah, these two are my differentials.
Okay. Can you ask for the remote control?
Yeah.
Okay. Scroll and give me your final diagnosis and manage.
All right. Yes, I'm scrolling. All right. These are the CT scan axial sections, unenhanced study. As I'm scrolling through the images, I can see that there is a hyperdense foreign body in the sorry, I think the images are not scrolling smoothly.
Scroll slowly and
Yeah.
candidate 4. And 4, we couldn't hear you. Can you hear me? Other candidates?
Yes, we can hear you.
Okay.
Maybe we lost her. Yeah. Uh, she will
I
be
think.
joining soon, I guess. Yeah, she will join.
Okay.
Hello,
Okay.
can you hear me? I think I lost my connection. Yeah.
Yes, yes, we lost you. Okay, you can continue. Okay. Candidate 4. Okay, we can go for candidate 5, and then when candidate 4 come back, he can continue. Okay?
Yeah, hi, this is candidate 5. Can you hear me?
Yes. Okay, candidate 5. I'll give you the history for your case. Just reset the timer. Okay, start. Okay, this is a 35 years old female patient with right upper quadrant pain. I will give you, show you the images of the ultrasound. You can start commenting, okay?
So this is the ultrasound images of the upper abdomen. There's a liver in view. And there is a echogenicity in the left lobe of the liver. Right. The pointer were on a well-defined mass in the periphery of the liver, just under the capsule, which appears to be echogenic. The borders are very well defined. There is no infiltration, no post-acoustic shadowing. Incidental gallstone in the gallbladder walls appear to be mildly thickened. I will check the vascularity of the mass of the liver. The rest of the capsule of the liver appears smooth, and the parenchyma of the liver is also smooth. There is no cirrhosis in the images. Can we
So
check?
what's your differential?
Echogenic area in the periphery of the liver could the differential could be like an adenoma or focal nodular hyperplasia. Third differential is a hemangioma, but hemangiomas are mostly very echobright lesions. So these will be my three differentials.
How will you differentiate?
If we have fat component in the lesion, that points towards adenoma. If the lesion is very echobright, that goes towards hemangioma. And FNH can look like normal liver parenchyma because it takes like normal Kupffer cells in it. So we will need an MRI scan liver protocol for this to evaluate this mass further.
How will you differentiate in MRI between these lesions?
I would look at the T2, T2 very bright without any central scar, and then I will check for the filling as well. So if it is hemangioma, it will be showing discontinuous early enhancement and then gradual enhancement without any washout. If it is adenoma, I will check at in and out of phase images to look for signal drop, to look for the fat component, because adenoma can show different patterns of enhancement. And if we have a fat which suppresses, that is in keeping with adenoma. Or it could be angiomyolipoma as well, which can contain fat. And then third is FNH. FNH will show T2 hyperintensity with the T2 hyperintense scar in the center. Then gradually it will show enhancement and without any washout. And then later on in the delayed 20-minute prima vista images, it will show contrast uptake.
Okay, scroll through the MRI.
Okay. So this weighted images of the liver. The lesion is homogeneous in appearance, and there is small fluid next to it in the left lobe of the liver. Rest of the liver looks okay. Normal, no splenomegaly, no evidence of cirrhosis, incidental gallstone. Can I look at the other sequences, please?
What other sequence you want to look at?
Can I look at the in and out of phase first and then contrast images?
Scroll. Click once and
So this is a phase. Can I check out of phase, please?
okay. Lesion.
This is out of phase. Focusing on the liver only, at that lesion only. So there is signal drop in that out of phase images, and then next to that, we can see T1 bright signal, which is in keeping with the blood products. Can I check contrast images, please? So far, this is in keeping with adenoma, and I will confirm it with the enhancement pattern.
What is the pattern of enhancement of adenoma?
It can look like anything, to be honest. So there is no particular enhancement pattern. It can show early contrast enhancement and then can wash out. But hemorrhage next to the lesion, signal drop in the.
Where is the hemorrhage?
I thought this is the hemorrhage.
How will you confirm?
So
What other possibility other than hemorrhage?
sorry.
What the other possibility other than the hemorrhage?
Well, this is T1 bright, so it could be hemorrhage or it could be fat.
Okay.
I check
Okay.
DI.
What about the pattern of enhancement of the lesion?
This is arterial phase. So looking at the lesion, it is homogeneously enhancing early rather than compared to the rest of the liver.
Okay.
I will check the
I'll
next.
give. Okay.
Mm, It is still retaining contrast, not watching out compared to the liver.
Okay. What's your final diagnosis?
A hepatic adenoma, which has acutely black. The size is, can't remember if it is, but looks like less than 5 centimeter. Because of the acute bleeding, this needs a discussion with the INR team and
Where is acute bleeding?
there's subcapsular acute bleeding there. Can you?
Okay. I'll give you. Okay. Leave the mouse.
Okay, I'm going slowly up again in this T2 sequence.
Okay. Will you biopsy this lesion?
No, these are highly vascular lesions. No need to biopsy.
Okay. This patient shoulder trauma.
Okay. This is the MRI sequence for a patient shoulder trauma. Are you scrolling?
Yes. Yes.
Uh,
Scroll slowly.
okay. There is abnormal depression of the anterior glenoid surface here. Sorry, anterior humeral surface here. I will check it. The other sequences. So this will be in keeping with the anterior, like reverse hill sac lesion. There is
Okay.
a of the glenoid labrum from the posterior surface. Uh, there is disruption of the anterior this glenohumeral ligament, the anterior labrum is intact, and I will look at the other study. There is a bony Bankart at the posterior surface of the posterior inferior surface of the glenoid. So findings are in keeping with the reduced shoulder, which was posteriorly dislocated in this patient. This is still unstable injury because of the bony Bankart lesion posteriorly, and then the very large reverse hill sac lesion. Um, I will advise urgent orthopedic, like shoulder is reduced, but this needs operation from the shoulder
Is
surgeon.
it Bankart?
Sorry,
Is it Bankart lesion?
bony posterior, like Bankart is anterior inferior, but this is like because of the posterior dislocation, like the reverse Bankart, bony Bankart.
Okay. Okay. How will you manage this case?
Shoulder is reduced. The patient needs to, they need to check the neurovascular intactness of the shoulder. And if it is intact, then shoulder surgeon needs to do stabilization procedure arthroscopically for this patient.
Okay. This 6 years male patient with fever and abdominal pain.
How old? Sorry, six.
Six.
6-year-old patient, fever and abdominal pain. Okay, so this is the frontal projection abdomen for a patient with fever and abdominal pain. I will look at the image and then start commenting, please. There is this catheter in the projecting over the right front. This is in keeping with the peritoneal dialysis catheter. The bone density also appears to be sclerotic for a 6-year-old. Sclerosis is present in the ribs, spine, and in the pelvic bones as well. Uh, Looking at the abdomen, there is dilated uh, bowel loops in the left quadrant, and the right quadrant there is fluid density there without any bowel shadows. And then if they are presenting with fever, um, there might be an element of infection. I'm looking for any thumbprint. Uh, I don't see any thumbprinting on the dilated bowel loops. Um, so in a there is a suspicion of, no, sorry, not suspicion. There is dilated bowel loops. and especially in the left quadrant where there is this very large gas-containing loop there, which is going towards the pelvis. So
Okay.
could represent an obstructed bowel. The causes in this patient could be because of the peritoneal catheter. There might be a sort of formation there, which is causing.
Anything else? Anything else in this image?
Um, looking for free gas. There is some like gas over the surface of the liver. Um, yeah, so that could represent a free gas because that's quite far from the lung shadow on the right side. So that is suggestive of pneumoperitoneum. I will.
Where is it?
Can you see my arrow?
No, no. Click once and show me.
Can you see my arrow now?
Yes.
Okay. This area over the liver.
Okay. Nothing.
Okay, that's fine. And then here the bowel loop appear to be quite thick-walled to me.
Okay. What will you do next for this patient? This patient complaining of acute abdominal pain.
Okay. I'm worried about this cutoff here. So this could represent like an intussusception point. If the patient is having a focal mass-like lesion in that right quadrant next to like in this region of the abdomen, that could represent an intussusception. That is one of the possibilities in this age group. I will advise surgeons to look at this child, and if they are worried then about intussusception, then we can do a focal ultrasound to confirm the diagnosis, look at the bowel, look at any fluid there, and vascularity of the bowel as well.
Okay. We did CT scan for this patient.
Okay. I will focus on the abdomen first and then look at the rest of the study. Okay, so kidneys are atrophic in hydronephrosis, which was in keeping with the findings which we saw. Uh, um, about okay, I'm go back slow. Right, so bilateral hydronephrosis and thick ball urinary bladder and peritoneal dialysis catheter is also in play. Bowel is showing contrast in it. I'm looking for any transition point or any abnormality. Okay, so there is some densities here in the region of the appendix, like I
Yeah.
said, and I'm just trying to figure out where the whether this is blind ending sac or can I check it in the coronary format, please, to confirm.
What are you suspecting?
Suspecting appendicitis here because there is fluid in this right iliac fossa, and then there are multiple appendicoliths there.
Okay. Use the mouse. Can scroll.
Yeah, so that's a blind end sac there with the appendicoliths in the right iliac fossa, and it has to be distended with fluid. So features are in keeping with appendicitis, and I will correlate with the infection markers, and then surgeons need to see this patient for management of the acute appendicitis. And I'm assuming that the condition of the kidneys and peritoneal dialysis catheter is already known to them.
Okay, thank you. Well done. Okay, Jones.
Yeah. Thank
Okay. Here, okay, peritoneal dialysis catheter. Okay, but if you look here, you can see. Please, all of you, can you mute yourself, please? Okay, you can see calcific density here in the right iliac fossa. Okay, as regarding patient, okay, much so one dilated bowel loop here, not so much other dilated bowel loops. Okay, so acute abdominal pain with calcific density here in the right iliac fossa, you have to suspect appendicitis. Okay, you can recommend ultrasound first because this patient 6 years old, so ultrasound will be safe. Okay, so but they did CT scan. On the CT scan, you can detect on the right iliac fossa there is a structure coming from the base of the cecum with multiple calcific density through it, and it is blinded in here. But there is inflammatory process surrounding it. You can see the peritoneal thickening and the mental stranding and the free fluid. So it is likely to be complete, and also fluid reach up here on the right side along the perihepatic region. So it is a case of complicated acute appendicitis due to obstruction of the appendix. Okay, so urgent referral to surgical team. In this case, yes, it is reversed Hill-Sachs, reversed Banker, and posterior labrum injury, and also there is polyps as posterior labrum sleeve avulsion. Okay, but here you can see the subscapularis muscle. You can also see the coronal. Okay, supraspinatus tendon is seen showing some hyperintense signal, and you can see there is joint effusion also, and there is disruption of the glenoid attachment of the glenohumeral ligament. So I need urgent referral to orthopedic. This patient, yes, hepatic adenoma, slightly hypoechoic lesion seen to the left lobe of the liver, well defined, no signs of cirrhosis, capsule is seen well. Okay, so it is likely to be benign lesion, differential as you told, adenoma, focal nodular hyperplasia, or hemangioma. We can differentiate between three of them by MRI. Hemangioma, as you told, endoarterial hyperintense on T2, endoarterial phase, discontinuous peripheral nodular enhancement with central filling through the rest of the dynamic study. Adenoma, we'll look at the pattern in phase, out of phase. Focal nodular hyperplasia will maintain the contrast and there is in the hepatobiliary phase, and there is central scar. You can see here, this is fat, okay?
Okay, so this is just abdominal fat.
Yes, okay. If
Sorry,
you
yeah.
look at the fat, if you are suspicious, you can tell the examiner, I will look at the fat set images, okay? So here the fat set is suppressed and the lesion also slightly suppressed. In phase, out of phase, very good. And if you saw here, in out of phase, okay, it is the lesion suppressed, but the subcutaneous fat not suppressed. So it is fat and it is adenoma. Adenoma can show arterial enhancement and rapid washout. Okay, and different pattern of enhancement, but the most important finding is suppression of signal on out of phase images. Okay, thank you, candidate 5. Candidate 4, can you come again?
Yes.
Okay, you can complete. You can ask for the remote control.
All right.
Okay, go ahead.
Okay, I'm tracing the right main bronchus. I can see that there is a hyperdensity noted adjacent to it with complete collapse of the underlying lung and ipsilateral mediastinal shift. In my routine practice, I will also like to see the corneal images for confirmation, and then I will urgently refer the patient to the respiratory team for. Okay, so these are the corneal sections. Yes, this is
Okay,
the trachea.
okay,
Yes, this is in the right main bronchus,
okay,
a hyperdense foreign body. So I will refer the patient for bronchoscopic retrieval.
okay, okay. This patient, 25 years old female patient with right upper quadrant pain and tenderness.
Okay, these are the grayscale ultrasound images of 25 years old patient who presented with upper abdominal pain and tenderness. On this image, I can see that there is a suprarenal lesion seen on the right side, which appears to be hyperechoic. Um, some fluid is seen in the hepatorenal pouch. This lesion measures approximately 6 into 5.4 centimeters, appears to be heterogeneous. No vascularity is seen on the color Doppler images. So in the young age group, the features are concerning for adrenal hemorrhage or adrenal hematoma. I will like to scan the other left kidney and left adrenal gland to look for the multiplicity of the lesion, and then I will refer,
What's your
convey my
definition?
findings. Yeah, differentials can be an adrenal hemorrhage or adrenal hematoma. However, the possibility of underlying adrenal gland mass cannot be ruled out. So I would like to further go with the cross-sectional imaging for further characterization.
Okay, click once on the spot.
Okay, these are the CT scan axial sections of abdomen, arterial phase study. As I'm scrolling down, I can see there is myelicitis in the region of the right adrenal gland. There is a heterogeneous lesion. It is causing mass effect on the right kidney. I can see hyperdensities in this lesion, which are concerning for contrast extravasation. Some areas of hypodensity are also noted in it. In my routine practice, I will like to take the Hausenfeld units also for this lesion. The left adrenal gland appears unremarkable.
Okay, what is the location of this lesion?
This is in the right adrenal gland. I will like to see it on the corneal sections also. First, I will like to see it on these images. It is this hemorrhage is seen to be encasing the kidney and is seen extending in the right perineal perirenal spaces. Myelolipoma, which has ruptured. Other possibility can be of any underlying pheochromocytoma, which has ruptured, or however, the left adrenal gland appears unremarkable. Uh, this is causing mass effect on the right kidney, causing its encasement. I'm also concerned about this contrast extraposition. I will like to see it on the delayed phases and photovenous and delayed phases also. And then I will
Wait.
urgently refer the patient
Candid,
to
or
IR
please,
team.
please.
Yeah,
Please. What is it?
this is right adrenal gland.
Okay. So what's
Yeah.
your final diagnosis?
Okay. So I can see some fat also in it, and I can see there is some north synovial along the lateral aspect of the right kidney. So second differential possibility
Okay.
could be of renal angiomyolipoma, which has bleeded and extended into the right perinephric space. I will like to see any previous images if available. Otherwise, I will refer the patient to IR team for embolization.
Okay. This patient, 20 years old, male patient, trauma.
20 years old male patient. Sorry, trauma?
Trauma. I will just use this. Okay. Trauma.
Trauma. Okay. Okay. Uh, this is X-ray of cervical spine, lateral projection. I can see that there is increased atlantodental space or predental space is increased more than 3 mm. Other than that, I can see that there is a subtle lucent fracture line seen along the posterior elements of the C1 vertebral body. There is subtle increase in the soft tissue swelling in front of the C1 region. The findings are concerning for Jefferson's fracture or atlantoaxial instability. I will gently convey the findings and refer the patient for urgent CT scan for further evaluation of these fractures.
Anything before CT scan you can do for this patient?
Yes, we will advise a cervical collar for stability so that the uh, cord cannot be like it's an unstable injury, so we want to protect the cord and cervicomedullary junction.
We can do open mouth view, okay?
Yes, we can do open mouth view. Okay, so on the open mouth view, there is asymmetry between the lateral masses. Their distance from the odontoid peg, it is increased on the left side as compared to the right side. Also, the facets of the C1 and C2 vertebral body are displaced laterally. C1 is displaced lateral to the C2 facets, which is further confirmation for the atlantoaxial instability and dissociation.
So the image give me a final diagnosis.
Okay, I can see that there is multiple fractures seen along the anterior and posterior arch of the atlas, which is suggestive of Jefferson's fracture. There is also prevertebral swelling suggestive of any adjacent hematoma. So I will urgently inform the findings to the trauma team for urgent neurosurgical input would be advised.
Okay, thank you. So here, as you told, the widened of the space between the anterior arch of C1 and odontoid peg, and also there is disruption here of the posterior element arch of C1. Okay, so highly suspected Jefferson fracture. This patient already put it in the collar because it is unstable fracture. Routine and trauma, we have to do open mouth view. We can see the lateral displacement of lateral masses of C1 over C2. So it is Jefferson fracture. On the CT scan, there is multiple fractures through the anterior arch and posterior arch of the C1. and there is displaced bone fragment here. Okay, this patient need urgent referral and may need also MRI. Okay, I showed you the adrenal. Okay,
Yeah, yeah.
it is normal. Why did you insist it is an adrenal lesion?
Yes, on axial, I thought it is maybe arising from one of the limb of adrenal gland.
Yes, but after I show you the coronal, you have to change your mind.
Yeah. Yes, yes. It is
Okay,
clear now.
what is the first possibility now?
Now, the first possibility is renal angiomyolipoma, as fat locules are also seen here.
Okay, so you can
Adjacent to it,
see
and there is
extension
not
on
sign.
the notch sign on the right side. Very important to look at the pre-contrast, okay? Because pre-contrast is showing hyperdense fluid and the fatty lesion, okay? So it is ruptured angiomyolipoma. Do you know the name of this syndrome?
Uh, I think Waterhouse. No.
No, it is Wunderlich syndrome,
No.
okay?
Wunderlich syndrome. Yeah.
Yes, Wunderlich syndrome. So you can see here the lesion extending to the cortex of the kidney, containing fat, but there really no evidence of contrast extravasation. Okay, but there is large hematoma,
Okay. Yeah.
so this patient need urgent referral to IR team for embolization. Okay,
Okay.
and this case we did very well. If you look here, you can see. Okay, this lung is normal, hyperinflated. This lung is abnormal. Okay, so the first possibility in acute symptoms, as can foretold, foreign body, you can see subtle hyperdensity here, but it is not convincing, and decreased lung volume. So foreign body aspiration is the first possibility. If the patient presents chronic symptoms, hypoplasia or agenesis can be a possibility. So this patient need urgent referral to thoracic team for bronchoscopic removal of foreign body. Okay, thank you, candidate 4. All the best. Well done.
Thank you.
Welcome. Candidate 6, are you
Yes,
ready?
Doctor. Yep.
How are
I'm
you?
here. I'm fine, thank you. How are you, sir?
I'm fine. Something for you. Okay.
Actually, yeah. But there appears no link for me to request remote control. If you can grant it to me or scroll for me, please.
You can scroll, yes?
No, I cannot because I don't have the link or the button for access for requesting.
I'll give you the remote control, yes?
Yes, please.
Okay. Now you have the remote control.
Yeah, right. Now I do.
Okay. Okay. So
Okay.
80 years old female patient with long-standing low back pain, no history of trauma.
Okay, so this is an old patient with low back pain, no history of trauma. These are bone scan images. These two both are in the anterior view and of different stages or phases of the scan. The left side one appears to be the earlier one, and the right side one is the later one. I can see that there is progressive increased uptake of a nucleide in different locations. Actually, it's in the upper mediastinum and one in the right lower rib, and another one in the right side of the sacrum, and a smaller one in the left side of the sacrum as well. Otherwise, the appendicular skeleton shows only some patchy, slightly have increased uptake in the region of the shoulder girdles bilaterally. Otherwise, there are no other foci of increased uptake. The kidneys are still could be seen. There is some uptake in the kidneys. So at this stage, and given the patient age and the presentation, my first diagnosis would be a metastatic metastatic malignancy. Probably it's arising from the upper mediastinum and metastasizing to the bone. Such cases are, this
Can
is
you look
actually,
at
it's another, I have additional posterior views for the same patient. In the posterior views, I can see that there is an increased uptake in one of the thoracic vertebrae in the lower thoracic spine. There is also H-shaped increased uptake in the sacrum. These two are suggestive of compression fracture in the thoracic spine as well as an insufficiency fracture of the sacrum. So my principal diagnoses are insufficiency fractures or
what will you do next?
Next is DEXA scan for the patient to assess the bone mineralization and refer the patient urgently to the orthopedics team for further management.
Before DEXA, always my colleagues, any nuclear study, you have to ask for plain radiograph. Okay?
That's right.
You can scroll through the CT scan images.
Okay. It says that the remote control is paused. Now it's working. I suppose it is.
It is working, yes.
Yeah. This is actually, I'm not sure if I can scroll. It's not working.
You can scroll. You start scrolling. Now you are scrolling.
Okay.
Scroll
So the other
slowly.
side.
Just scroll slowly.
Okay. Okay. It's scrolling fast now. All right. So this is pelvic bone CT scan images. Okay, and I'm just trying to scroll until the last cut. I believe this is the last one from Codally. And as I'm going up, I can see that there is a right femoral endonail or a prosthesis. The pelvic bones appear intact so far, and I can see also that there are the
Ignore about that image. Okay.
Okay, I do. It's stopped here. So this is the last cut. Can I go back again?
Yes.
Okay. So there is increased density around the sacroiliac joints on both sides of the sacroiliac joints bilaterally, almost symmetrically, with some irregularity of the sacroiliac joint space. The findings of the cyclopetic changes are more prominent on the sacral side rather than the iliac side. And these are suggestive of bilateral, almost symmetrical sacroiliitis. So in this patient, I suggest that the differential diagnosis include psoriatic arthritis and IBD-related sacroiliitis. The ankylosing spondylitis and IBD-related sacroiliitis. Other differentials are late stages of psoriatic arthritis and reactive arthritis. And for that, I would recommend correlation with the clinical findings first, and surveying the rest of the skeletal bones to rule out other associated findings of the anterior ankylosing spondylitis. And if the patient has any history of bowel changes, bowel motion changes, then it would suggest probably a different scenario.
Okay, this 75 years old male patient with shortness of breath.
Right, so I'm presented with a lateral radiograph or scout view for a 75-year-old gentleman who presented with shortness of breath. In this sagittal image, I can see that there is an significantly increased prevertebral space thickness, thus compromising the upper nasopharyngeal and oropharyngeal airways, the upper airways in general. And given the patient age and clinical data, I suggest that that could be a lesion in there or a abscess. So to further assess the lesion, I need to recommend for the patient a CT scan with contrast.
Any other possibility other than abscess? Can you see any evidence of abscess here?
No, I cannot see any fluid levels or gas within the soft tissue. So that a lesion is more likely, but the bones appear intact. I cannot see any erosive changes. Uh, um, I cannot see on this image any other bone changes to suggest a malignant lesion. So, nasopharyngeal carcinoma is still one of the differentials, and other differentials are inflammatory process. I can see also no foreign bodies to suggest. Yeah. Okay. Okay. So, given these images here. I'm trying to scroll through the images slowly. I can see a gas-filled cavity in the prevertebral space that's communicating with the nasopharynx. As I'm going up, the cavity ends.
Is it gas?
It's either gas or fat. For that, I would usually
From the radiograph.
on the radiograph, it's of a soft tissue density.
Okay.
So it goes more towards fat containing lesion in the prevertebral space. And it's abutting, actually, it's not communicating with, it's abutting and narrowing the oropharynx and nasopharynx. However, the lesion is also extending into the right parapharyngeal space, and it's abutting or obliterating the right parapharyngeal space fat, or maybe arising from there. There are also laryngoceles bilaterally. They are internal laryngoceles bilaterally. So regarding this lesion, a fat-containing lesion in the midline, I would consider first a dermoid lesion, although in this patient age, it's unlikely. Other differentials include a lipoma, especially it's well circumscribed.
Okay, how will you manage this case?
I will probably need a MRI for further evaluation and
What is the
assessment.
value of MRI?
Extension into the adjacent structures, especially with contrast and any possible liposarcomatous changes if this is a lipoma. Otherwise, the patient would need biopsy from the lesion, sending the patient to the ENT team, and the patient should undergo biopsy, MDT discussion, and further surgical management.
Okay. This patient, 60 years old female patient with GCS3 post-traumatic.
Right. So I'm presented with a brain CT scan for a 60-year-old lady who presented with the GSC score of a 3. That's the lowest GSC score, actually. So the patient underwent a trauma. I would be looking for trauma-related findings that could lead to similar changes. Right. So in the available coronal images, I can see multiple areas of increased density in the subarachnoid spaces bilaterally. It's involving almost the parietal and temporal lobes bilaterally. There is also some hyperdensity seen in the left parasagittal aspect of the falx. The superior sagittal.
Okay, you can scroll through the images.
Yeah.
This is the last.
Yeah, so I'm going the other way around. Yeah, right. So, oops. Okay.
Wait, scroll slowly.
Actually, I just clicked once, but it's just running fast.
Yeah. No, just one by one.
Okay. So this cut, I can see that there is a multiple hyperdensities, as I said before, in the frontal and parietal sulci. There is also in the parafalcine region, there is a rim of hyperdensity again. and there is in the right frontoparietal subclavial soft tissue swelling as well. So given these findings at this stage, I can see that there is also blood or let's say fluid densities in the posterior horns of lateral ventricles and in the third ventricle. These are dependent portions of these fluid densities is the higher density in keeping with the blood densities. So collectively, this patient has subarachnoid hemorrhage, intraventricular hemorrhage, and subdural hemorrhage in the parafalcine region. I would also search for other hemorrhagic foci or collections in the epidural space. I just cannot see any. And
Okay, what's your final diagnosis?
yes, my final diagnosis are multiple hemorrhages in the subarachnoid, parafalcine, subdural, and intraventricular acute hemorrhages. I can see no evidence of herniation or diffuse brain edema. However, there is a right subgaleal hematoma or collection that needs further assessment by bone window to assess any associated bone injuries as well. Otherwise, I would immediately call the trauma team. The patient needs urgent attention for these findings and management.
What is the type of brain injury here?
It's diffuse brain traumatic injury, but there is no. There's also intraparenchymal hemorrhage in the right cerebellar hemisphere just appeared. However, there are no herniations.
Okay, if you presented with a patient with low Glasgow coma scale with multiple hemorrhages through the brain, brainstem, cerebellum, corpus callosum, what will be your diagnosis?
Actually, in my routine cases, I diagnose that as hypoxic ischemic encephalopathy or diffuse brain ischemic injury. However, I can still see the differentiation of a gray-white matter junction. Other differentials include venous thrombosis or occlusive changes in the arteries, major arteries like dissection that causes these findings as well. However,
Okay.
I cannot see any intraparenchymal hematoma other than the right cerebral. So I cannot suggest a diffuse axonal injury in this case. Otherwise,
Why you couldn't suggest a diffuse axonal?
actually, I cannot see any gray-white matter hemorrhages, callosal hemorrhages.
What is it? What is this?
Okay. I didn't see these on the while scrolling. Scrolling was really difficult for me.
No problem.
Okay.
No problem,
okay.
Dr. Ahmed, but I want to tell you something.
Yeah.
Diffuse axonal injury come from the history first.
Yeah.
Well presented by traumatic patient with very low GCS. Okay. Multiple hemorrhagic foci, okay, through the brain first, okay. You should, and small contusions, not so big hematomas, okay, due to shearing forces, okay. Well, both diffuse axonal injury in your first list, okay. Then you have to grade the diffuse axonal injury. If it is only involving the brain parenchyma or gray-white matter junction, it will be grade 1. If it is involving the corpus callosum, it will be grade 2. If it involving the brain stem and the cerebellum, it will be grade 3. Okay? So the history is very important. Okay? And this patient is comatose. So diffuse, think simply. I brought for you the case for simple thinking. Okay? Don't go away here and there. Okay?
Yeah, but I couldn't see these gray-white matter junction foci. The scrolling was just going fast between images.
I know that's wrong, but I thought you diagnosed the case from this image. Okay. Okay. It is actually diffuse axonal injury. Okay.
Yeah.
Simple. This case, okay, it is here. What against infection? You can see no gas here, okay? This soft
Yes.
tissue swelling, smoothly indenting the airway, okay? You can see it like this. And the airway is compromised. No any bony changes suggesting it is prevertebral abscess, okay? So it is likely to be a benign lesion, not malignant, prevertebral or retropharyngeal lesion. Just we need from you this in this scanogram. Then we have to go. Why air not a possibility?
Because it's soft tissue density on the radiograph.
Yes, yes. If you saw here, this is the air density, okay, and this soft tissue density. So even the window is not good for fat. So it should be
Right.
fat. Okay. So it is large retropharyngeal lipoma. So here we have to maintain the airway and urgent referral to the ENT team for surgical remove. Okay. Whatever liposarcoma or lipoma, it will be surgically removed and underwent histopathological correction. In this case, you diagnosed it from bone scan. Okay. My idea in the case, not this case itself, my idea is that in any bone scan, you have to correlate with the plain radiograph. Okay, this is Honda sign, so it is sacral insufficiency fraction. We did the plain radiograph first or CT first, then we go for the nuclear study. Okay. So after nuclear study, so it is insufficient fracture, and here maybe osteoporotic fracture from the of the one of the lumbar vertebra. So if you go for the CT scan, look at the area of interest. Okay, you can see subtle sclerotic line through the sacral ila. Okay, not so much it is within the coronal. Yes.
Yeah.
Okay.
I was looking for a definite fracture line I couldn't see, and it was
No
like
definite fracture line in insufficient fracture or in stress fracture. Sometimes you couldn't see the fracture itself, some sclerosis only. Okay.
yeah.
And then you have to go for the bone scan or MRI to confirm the presence of the fracture. Okay. Some degenerative changes around the sacroiliac joint. Okay, but it is not sacroiliac. Try to be simple. Okay, you are doing very well, but try to think simple and logic. Okay, and don't if you are if you are going in the right way, don't change your mind in between. Okay, this will give the examiner an impression that you are not confident. Okay.
Okay.
All the best, inshallah, in the exam. Okay. I will see the question. You will not see it otherwise. Why bone scan? Okay. Someone asked about the IBC in angiomyolipoma case. Okay. IBC there is IBC is good. Okay. You can see the IBC here. Just mass effect of elevation because it is retroperitoneal hematoma. Okay. Okay, my colleagues, all the best, inshallah, in the exam. Try to go simple thinking through the cases. Don't go so or far diagnosis. All of you are doing very well, but try to be relaxed. Try to be safe. And inshallah, all the best in the exam. Thank you so much.